Hi, this is Brian Kim. I'm going to share with you case number 212 in the Best Way to Do Cataract Surgery series. This patient has a fairly soft lens. That's not the reason I'm sharing this case. This patient has one of the worst floppy eyelids I've ever seen. And also a very strong Bell's reflex, which just makes it worse. You're going to see how I'm going to control the eye using the cannula and then efficient double chop and cross chop technique. This is the other thing. This patient undergoes intravitreal injections by another doctor. As I place the speculum in, look what you see here. You have two huge pledgets mixed with mucus and eyelashes. I was completely shocked when I saw this. This was in the eye the entire time. So I didn't see it until I placed the speculum. Of course, the patient's squeezing, and that must be why it herniated forward, because the patient's squeezing hard. So we go ahead and very gently remove these two pledgets mixed with mucus and eyelashes. Okay, the fact that there's two pledgets means that it was been there multiple times for multiple injections. I can't fault the other doctor because this patient must have had such fleshiness, and the eyelid fornix is so deep that it was like this cavernous space where the pledget just kind of fell back into. Nonetheless, we took the pledgets out, and you can see here it's blurry. That's because I went ahead and put some betadine in and really cleaned up the surface. I didn't really feel comfortable with that. We flushed it a lot more, put a lot more betadine in, and I'm just going to reassessing what to do here. Look at this lid, the upper lid. It's just spontaneously everted with the drape. I mean, look how fleshy the tarsus is. It has no stiffness whatsoever. It's so loose. You can see the herniation of the conjunctiva, the lid. I'm just trying to push the lid back. I'm trying to get the tarsus back flat, but you can see all that conjunctivochalasis is herniating forward. It's just crazy. This patient must have such cavernous cul-de-sacs. Those pledgets were like trapped, incarcerated into the cul-de-sac of this patient. And so obviously I had to stop, put a lot more betadine in. And then, this is going to be a little bit of a challenge because you're going to have all this conjunctiva, conjunctivochalasis. The patient's going to have a lot of retropulsion of the eye as I'm trying to rotate and control the eye. And on top of that, this patient has a really strong Bell's reflex. So again, a very unusual case, but a good one to share here. So I'm using the cotton tip to control the eye. Sometimes if you have trouble controlling the eye because the cotton tip has become saturated with fluid, then just switch the cotton tip. And so that's what I did here. And I'm turning the eye down. This is the right eye, turning the eye down with the cotton tip. And then I'm using a corneal marker, which will help me to center incisor-rhexis. I loosen my cotton tip grip because the eye wants to turn up, which is towards the left of the screen. I make my paracentesis incision on the right side, making sure I'm parallel to iris plane. I ask the patient to look down. They're having a little bit of trouble. Look at all that flesh. Look at all that flesh that's covering the limbus. I mean, it's just crazy. So this patient's not able to control the eye. So I go ahead and use a forceps. I always like to put the teeth inside the incision, and by doing it that way, I'm gripping the sclera. I'm not going to be gripping the forceps on the corneal epithelium. You don't want to cause an abrasion. So I'm turning the eye down with forceps. I have no choice. Make my paracentesis on the left side, and while I'm still holding the eye, I switch from the blade to the cannula, and I'm injecting epinephrine. Once I'm done with that, I switch, but I'm holding the eye because there's so much oil. I ask my assistant to flush the surface, and then once they flush it, I switch to the dispersive viscoelastic cannula, filling the anterior chamber, and then I'm using that cannula to hold the eye steady and straight. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. Of course, I could have stopped and then done a block, but I didn't feel like that was necessary. I felt confident that I can control the eye. So I'm using that cannula now to control this eye, and it's always easy on right eyes for me to be able to place that cannula in through that left side paracentesis, which is again on the top of the eye, and it really controls the eye and able to pull it downward. And this is the Moria microrhexis forceps. I puncture the center, going around circumferentially. Minimal OVD egress, excellent control. But if I lose control, I can always push more OVD if I need to. Finish off the rhexis, burp some viscoelastic out. And then here, when I do my hydrodissection technique, I'm going to have to release that cannula. So of course, I release the cannula. You can see the eye immediately goes up. So this is the capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, get a nice wave. You can see the lens pops up, so you know it's going to have a good loose lens. Decompressing the bag. Making sure I put the lens back into the bag. Sweeping under the rhexis edge, and the lens begins to spin. So again, look how bad this Bell's reflex is, all this conjunctival chalasis, all of this flesh herniating forward. Go ahead and lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Removing more epinuclear material, placing the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, fracturing the lens in half, that's double chop. Placing chopper under the right heminucleus, hooking the peripheral lens, pulling it centered toward the phaco tip, fracturing the right heminucleus, that is cross chop. That first quadrant comes right up, so I eat it up. Placing the chopper under the second quadrant, and it pops right up, and then I eat that piece as well. Grabbing that other fragment with some vacuum, and it pops up into the anterior chamber, and then the fourth quadrant comes right out easily. So again, fairly soft lens. Disassembly here is not really the main point. It's fairly easy to disassemble a soft lens with this technique. Again, I would say divide and conquer. Any sculpting techniques with soft lens is probably a bad idea because it breaks apart, and you don't. And folks who do that tend to try to go after pieces with vacuum, which is probably not safe. But using mechanical fracturing really is very easy with soft lenses. You see I had to reposition the eye because this patient has moved off the screen so much, off of my focus. And so I go ahead and reposition. And then I'm going after the epinucleus. And that went fairly quickly. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. You can see there's quite a bit of reverse pupillary block, but this patient's doing fine, didn't really say much to me. Go ahead and start to remove the cortex from anterior to posterior. You can see how loose the cortex was, so it just all pops out. Switch to polish mode, polishing under the rhexis edge, making sure I tease the fine fibrils from the capsulorhexis, sweeping the lens epithelial cells as well. Polishing the posterior capsule, there's quite a bit of adhesions of fine lens material on the posterior capsule, and then sweeping some more and polishing into the fornix. Pulsing into the subincisional capsule fornix with the BSS cannula. And then injecting cohesive viscoelastic. Before I do that, I disengage the irrigation, turn it off, and then push the cohesive viscoelastic to fill the bag. Using the cannula to control the eye and keeping it straight because this patient has such a strong Bell's reflex. I'm going to sweep under the left side, but I'm using the cannula to hold the eye straight. Once I'm done with that side, I switch, placing the sweep in the left side incision. And because I'm able to control the eye and move it downward with that sweep, it kind of kills two birds with one stone. I can control the eye as well as sweeping under the right side. Placing the single piece acrylic lens into the capsular bag. Making sure the leading edge of the lens goes into the bag, and then quickly switching back to the eye handpiece, going in with irrigation off, activate irrigation, making sure both haptics are disengaged off the optic, getting under the lens, rotating it 90 degrees, tilting it, making sure both haptics are in the bag, removing all the viscoelastic from within the bag. Polishing under the rhexis edge. And then I'll remove the viscoelastic from the anterior chamber and I'll hydrate my incision. So again, this is a patient with a terrible Bell's reflex, terrible floppy eyelids. You see how much flesh there is that's tried to cover over the eye. You saw there was so much conjunctival chalasis and just that flesh herniating upward. There's probably quite a bit of fat as well, herniating forward, covering the limbus. And you saw how I was able to very carefully and systematically be able to disassemble the lens confidently in a soft lens like this. Again, you saw, again, in the beginning, those pledgets in the cul-de-sac, which was totally surprising. It just goes to show these patients with this floppy eyelid phenomenon, just very unusual anatomy. And you just have to be very careful when you do cataract surgery in this context, especially strong Bell's reflex. You saw how I was able to navigate around this by using the cannula to keep the eye straight, using a two-handed maneuver for all of those steps. And I think that's really the key when you're doing these challenging cases, being comfortable using two hands, maneuvering around the eye to give yourself a competitive advantage and some leverage over this patient's eye who tends to want to look all the way up to the top of his head. And again, putting more betadine after we found those pledgets to really provide sanitized surface of the eye before we get started with the surgery. And thankfully, this patient did very well. So hope this was helpful to you, and I thank you for your attention.